I am Dr. Lina Renales from the Philippines. I have been practicing for probably 35 years as a neurologist, and I am a member of the Philippine Neurological Association. And I had training at Mayo Clinic regarding neuromuscular diseases, particularly myasthenia gravis. So I think this afternoon will be focused on myasthenia gravis. Okay, of course, we first base on history. There's a variability of weakness and there is fatigability in what part of the body the patient is complaining, whether it's in the eyes or the proximal muscles of the body. So by history, you have more or less an inclination of what you are dealing with. And of course, the first test ideally is a tensilon test in the lab in the hospital, but if it's not available, we do with a neurophysiologic test, which is a repetitive nerve stimulation test, and or the single fiber EMG. So by this, we expect to find a decremental response in the repetitive nerve stimulation, and also the single fiber EMG will show a characteristic pattern for myasthenia gravis. And of course, the most examination or diagnostic um, is the serology or the acetylcholine receptor antibody test. And that is the definitive diagnostic exam that will clinch the diagnosis that you're dealing with myasthenia gravis in conjunction with history and physical examination. Oh yes, in examining neuromuscular disorders, since myasthenia the most is the eyes, so we focus on the eyes. So we ask the patient to look upward for 1 minute. First, you measure the lid aperture before at the start of looking up, and after 1 minute, you start measuring it again. And there, you demonstrate the ptosis or the weakness of the levator palpebrae muscle. Okay, so that's one muscle to be tested, and then the extraocular muscle movements to be tested, and as well as the orbicularis oculi. You ask the patient to tightly close the eyes, and then you try to open it. And if there is weakness in the orbicularis oculi, you can easily open the eyes. So another one is the orbicularis oris in the mouth. Then you ask the patient to purse the lips, and you try to open the lips, and you see if there's weakness in the facial muscles. Also in the neck muscles, you try to oppose the flexion of the neck, and you can see also weakness. For the proximal deltoid muscles, we ask the patient to stretch the arms in front like this for 1 minute, and you see if there's weakness, the arms will drop little by little. So you can see that those are subtle fatigability or weakness of the muscles due to fatigability. For the lower extremities, we ask the patient to squat 10 times. And if he is unable to do 10 squats, then probably there's weakness of the quadriceps muscles. So we test for proximal muscle weakness. And that's the physical examination where we are given the hint that this is probably myasthenia gravis. So if we do tensilon test or edrophonium test, of course, there are risks that is associated with that drug. So it can cause bradycardia, or it can cause cardiovascular problems, like arrhythmias, and also hypotension. And so we have to do it in a hospital setting where you can have atropine at hand to counteract the effect of the edrophonium. The other one, the next test is the repetitive nerve stimulation test, which is a painful test for children. So you have to warn the parents that this is a painful diagnostic test, that doing this test will really be not is not comfortable for the patient. And
The next is the serologic exam, which is the antibody test. And of course, it is a blood extraction. And so usually kids kind of hard to submit themselves to blood extraction. So these are just the risk of the diagnostic test. Otherwise, it's fairly straightforward. Okay, ocular myasthenia gravis is the very mild form of myasthenia gravis, which is focused on the eye muscles. So the initial symptom is just ptosis or drooping eyelids, and variability, but usually the symptom is variable. There is fatigability. So in the morning, the ptosis might be not evident, and it's only evident in the afternoon. And in some patients, but if it's sometimes sudden, when they wake up, the eyes are already closed, then you have to differentiate it from other neurologic disorders like cranial nerve paralysis of the third nerve, or probably a stroke if it's in an adult patient, and probably other cranial nerve palsies as in diabetic neuropathies. So this you have to think about if the presentation is atypical for myasthenia gravis. Because in myasthenia gravis, we get a history of variability and easy fatigability, which you don't have in the other cranial nerve diseases, as well as strokes, which is a permanent, deficit, unlike in myasthenia, which is fluctuating. So in ocular myasthenia gravis is very mild, so we just treat them with pyridostigmine or acetylcholineesterases and observe if it will develop into the generalized type. But some of the patients just stay at the ocular myasthenia gravis form of the illness. Usually when I start immunosuppression in myasthenia gravis, I start with steroids or prednisone. Whatever the age of the patient, we start with prednisone. And if we find improvement with the steroids or prednisone, then we just continue with the drug and taper it and observe if the symptoms will come back if we remove the steroids. Now we consider azathioprine or the more other immunosuppressants. If the symptoms recur after the first course of steroids, or if the generalized myasthenia gravis is severe at the start, say they start with crisis, then we combine both steroids and azathioprine together as a start of point. And then observe the development of the patient. You give the maximum dose of 1 milligram per kilogram of steroids and 50 milligram initially of azathioprine, increasing it to up to 150 milligrams a day, and observe the improvement. But of course, you have to watch out for the bone marrow suppression in azathioprine. So you have to monitor the red blood cells in the complete blood count to see if there is some immediate reduction of the red blood cells. And if say in a course of, we wait for at least a year for the azathioprine to kick in. Usually azathioprine just kick in 2 months time. It doesn't kick in the first week or 2 weeks. You need about 2 to 3 months or even 6 months. So we observe azathioprine for 6 months to a year and see the development of the course of the disease. Now, if there's no improvement and there's still progression of the symptoms, then we shift to either mycophenolate, mofetil, or even cyclosporine, or even cyclophosphamide, even depends on the comorbidities of the patient, depends on the if this is a young female, of course, she might want children in the future, which can be affected by more stronger immunosuppressants like methotrexate or cyclophosphamide. which can cause severe side effects in as neuropathies or falling hair, sort of. So you have to communicate with the patient and really plan the treatment you want to do. Or if your patient is pregnant, or as in in pregnant myasthenics, I do had patients with myasthenia gravis who went into pregnancy, and of course I have to remove the steroids because steroids is bad for the fetus, and I cannot give immunosuppression. So I have to do only pyridostigmine or mestinon at the time of pregnancy, especially in the first trimester of the pregnancy. So I have to remove immunosuppression and watch out for and ask the patient just to rest at home because they have easy fatigability, and the course worsens if they are probably working or in the hot environment. So it's better for them to be in a cold environment to prevent fluctuations of the symptoms in myasthenia gravis. So it's more just mestinon for the pregnant female myasthenic. Okay, the most common antibody is acetylcholine receptor antibodies, and it's present in 85% of myasthenia gravis patient. And 6% have the MuSK antibody or tyrosine kinase antibody, and it's about 6%. So the rest, I think, is the negative antibody test for this myasthenia gravis. So if the testing is negative, it doesn't really rule out myasthenia gravis because there are a lot more antibodies that are present in these patients. And there's also a, a, a portion of them have seronegative, really, myasthenia gravis. And if you use cell-based, the usual test is radioimmunoassay, the usual test. So this cell-based test is the cells were primed, and then you put the antibody sera in them, and they say that it increases the yield by 50% more sensitivity if we use the cell-based test. So, but I think this is not really available in our country. It's not available. Even the radioimmunoassay is not available. We send our samples abroad, like in the US. So these cell-based tests are a new technique to increase the yield for the seronegative myasthenia gravis patients. Okay, the pathogenesis of myasthenia gravis is, of course, autoimmune antibodies present in the bloodstream of these patients, which was theorized to start from the thymus. So there is this has been triggered in the thymus, the T cells, which has been exposed to the myeloid cells, and thus the B cell factory is the one producing these antibodies, acetylcholine receptor antibodies. So this rituximab, which is a CD20 monoclonal antibody, attacks the CD20 positive B cells and, of course, eliminate them. So the less B cells you have in your body, of course, the less antibodies will be produced to improve the situation in myasthenia gravis. So this is also used in other autoimmune diseases like rheumatoid arthritis. It's also used in SLE. So other autoimmune diseases uses rituximab. So this is new in myasthenia gravis, and we only use it if azathioprine and steroids are the fail. So we consider this for refractory myasthenia gravis patients. And since it is very expensive, this drug is very expensive, although it's just given once a month or once a week. But it is very expensive here, especially in the Philippines. But there were some reports that it really improves the course of the myasthenia gravis, especially those who have gone into crisis several times. So
Right.
it is
Okay.
this is a really a promising treatment for myasthenia gravis. Usually we get referrals from ophthalmologists rather than the general practitioners. Because usually the general practitioners, if they see ptosis, they send them to the ophthalmologist or the eye doctor. So that is where we get most of our referrals from the eye doctor. Since most patients, as they are, I have seen several patients that were misdiagnosed, and they were diagnosed as mild stroke because of weakness of a limb, or because of the dysarthria, sometimes the difficulty of or talking or swallowing, they have been misdiagnosed as stroke, mild strokes. So that's the time they refer to the neurologist, because the general doctor would think it's a stroke, and so they go straight to us. But if the myasthenia patient presents with eye signs like double vision or ptosis, they go to the eye doctor. They are being referred to the eye doctor. And if they have dysphagia, they are being referred also to the ENT before it goes to us. So what I think is the most important here is the history. They should get the fluctuating type of weakness, that it's not a straight weakness. I mean, from day one to the time they see the doctor, the weakness is fluctuating. Sometimes they're strong, sometimes they're weak. So that's the real clue that you're dealing with myasthenia gravis. Unless it's probably hypokalemia, then you have to differentiate that also. So, but the most important is really in the history uh, and the physical examination, more than the additional tests that we will be doing. At the same, but during these COVID times, I try to shy away from immunosuppression unless the symptoms are really severe that they need the steroids and immunosuppression. But I just keep them on steroids and really warn them not to go out of the house or really be exposed to crowds that where they can get the COVID. Mm. But regarding vaccination, I have told my patients not to be vaccinated, since even a flu vaccine or a pneumococcal vaccine can flare them up, can flare the symptoms in autoimmune or any kind of autoimmune disease. So I just really tell them to really be careful, not to go out and to avoid crowds to get this virus, because that's the only ways. And hopefully, when we reach the herd immunity, then probably they can go out at that time. So as of now, I just tell them to really stay home and avoid the crowds and avoid COVID, getting COVID, because it's they might since they are immunosuppressed, it's very hard for their immunity to really probably fight COVID virus. Yes, yes, you're correct. Uh, Symptoms in neurology is so variable. It can be really mild to very severe, and only the severe ones go to the doctor. So if they're just mild, like in migraine, mild headaches, they won't probably, since it's relieved by paracetamol or acetaminophen, they won't go to the doctor unless they are debilitated or they can go to work. In other neuro diseases, that's the thing also. We see strokes in their advanced, when they cannot walk already. They don't go to the doctor for TIAs, or even like what this is like here in COVID encephalitis. They won't go to the doctor unless they have a seizure or have a stroke or have a severe headache. So the start of COVID in neuro is like the anosmia or the loss of taste, they won't seek a consult for that. And they will only consult the doctor if they are debilitated already and it's a severe illness already. So that's what's hard with neurologic diseases. They don't seek consult unless it's debilitating or the symptoms are really uh, beyond their means. So I think the public has to be educated or be more aware of the very subtle signs of neurologic diseases. Even a mild headache or even a numbness, mild numbness that come and go, they usually won't consult. They will only consult if the numbness is permanent. Or the pain, if the pain is just mild, they wouldn't consult a doctor. They would just go for it, sort of. So I think we should educate the public really to be more listening to their body, especially for neurologic symptoms, to seek consult at the onset of whatever abnormality they have.